Good morning, everyone, and welcome to our lecture on the role of government in health economics. Today, we are going to build on our previous discussions of market failure and delve into the practical reasons and methods governments use to intervene in healthcare. We'll start with the economic theory behind intervention and then apply it to real-world examples, particularly focusing on the different approaches taken by the United States and Canada. The goal is to move from abstract concepts to a concrete understanding of how government actions shape health systems, health outcomes, and the lives of citizens. Here is an overview of what we'll be covering today. We'll start with a quick recap of what we discussed in our last session on market failure, which will provide the foundation for today's topic. Then, we'll explore the various tools governments have at their disposal, from simply providing information to directly financing and providing care. Next, we'll dive into the economic justifications for these interventions, using concepts like public goods and externalities. After that, we'll shift our focus to the real world, analyzing the major problems in the U.S. healthcare system and the different reform proposals that have emerged. We'll then consider two case scenarios that will help us apply these concepts to practical policy dilemmas, including a comparison of the U.S. and Canadian models. Finally, we'll address the concept of government failure and discuss the ongoing debate about the appropriate balance between the public and private sectors. As we recall from last week, a market failure is a situation where the allocation of goods and services by a free market is not efficient. In healthcare, this manifests in two primary ways: inefficiency and inequity. Inefficiency can stem from issues like information asymmetry, where patients don't have the same medical knowledge as their doctors, leading to moral hazard or supplier-induced demand. Inequity, on the other hand, is when the market fails to provide care to all who need it, often because they can't afford it, which conflicts with a societal belief that healthcare is a right, not a commodity. It's these systemic failures that create a compelling argument for governments to step in and try to correct the market's shortcomings. One of the most basic and least intrusive forms of government intervention is simply to inform and persuade. The government uses its unique position to act as a source of credible public information. A classic example is the public health campaigns against smoking or promoting healthy eating. The government doesn't ban cigarettes, but it makes sure the public is aware of the risks. This type of intervention is appealing because it respects individual choice while attempting to correct for a lack of information in the market. However, it's also limited. It only works if people choose to act on the information provided. Regulation is a more direct form of control, where the government sets the rules of the game for private actors. A powerful example is the Food and Drug Administration, FDA in the U.S., which regulates the safety and efficacy of all drugs and medical devices. Another form of regulation is setting standards for insurance plans, such as requiring them to cover specific services. Mandates are a particularly interesting type of regulation because they tackle problems without incurring direct government spending, which is often appealing to legislators. For instance, an employer mandate might require all businesses of a certain size to provide health insurance to their employees. The government isn't paying for it, but it's forcing a behavior change in the private sector to achieve a public good. This is often where the most significant government involvement occurs. Financing means the government pays the bills for care, usually through taxes. Think of Medicare in the US or the entire healthcare system in Canada. The government collects money and then uses it to pay providers. Providing, on the other hand, means the government actually owns and operates the facilities and employs the staff. The Veterans Health Administration in the U.S. is a good example of this. The key takeaway is that these two functions can be separated. Canada's system, for example, is a single-payer model where the government is the sole funder, but most hospitals and doctors' offices are still privately run. This is a crucial distinction that separates it from a system like the UK's National Health Service, where the government both finances and provides most care. The concept of public goods is a core economic reason for government intervention. A good is non-rival if one person's consumption of it doesn't reduce its availability to others. For example, my benefit from a public disease control program doesn't diminish your benefit. A good is non-excludable if it's impossible to prevent someone from using it once it's been provided. This is where the free rider problem comes in. A free rider is someone who benefits from a good without paying for it. Because private companies can't charge for these non-excludable goods, they have no incentive to produce them. The government must step in to provide things like sanitation, clean water, and public health surveillance, which are essential for a functioning society. Externalities are a second key reason for government involvement. A positive externality is a benefit experienced by a third party, and it's not reflected in the market price. The classic health example is vaccination. When you get vaccinated, you not only protect yourself, but you also contribute to herd immunity, protecting those who can't be vaccinated, like infants or the immunocompromised. The market would underproduce vaccinations because the price only reflects your personal benefit. A negative externality is a cost imposed on a third party. A factory that pollutes a nearby river is imposing a cost on the community that relies on that river for water. The government can use tools like subsidies for positive externalities and taxes for negative ones to internalize these costs and benefits, leading to a more efficient outcome. An incomplete market is a situation where a private market simply fails to exist for a particular good, despite there being a demand for it. In healthcare, this is a major issue with health insurance. Private insurers operate by pooling risk, and they need a mix of healthy and sick people to make a profit. If they only insure sick people, they'll go bankrupt. This can lead them to refuse coverage for individuals with pre-existing conditions, leaving a large segment of the population without access to insurance. This is a classic example of an incomplete market. The government can correct this by mandating that everyone buy insurance, thus forcing a large risk pool, or by providing a public option, ensuring no one is left out. The concept of merit goods is a more normative, or value-based, justification for government intervention. These are goods that society believes individuals should consume, even if they don't have the desire or the means to. Education is the classic example, but in many societies, healthcare is also considered a merit good. The argument is that people may not fully understand the long-term benefits of preventative care, or may undervalue their own health due to lack of information, or simply a present bias. In this view, a society that values the health of all its citizens will ensure access to care, regardless of ability to pay, justifying the existence of universal healthcare systems. Unlike some countries with a single national system, the U.S. government's involvement is a fragmented and complex patchwork of programs and policies. It includes direct provision for specific groups like military personnel and veterans through the Veterans Health Administration. It has powerful regulatory bodies like the FDA. The government is a massive financier of care through Medicare for seniors and Medicaid for low-income and disabled citizens. And finally, government tax policy plays a huge, though often overlooked, role. The fact that employer-sponsored health insurance is tax-exempt is a major driver of the U.S. system, as it encourages businesses to provide coverage, which effectively subsidizes the private insurance market. One of the most significant issues in the U.S. healthcare system has been the number of people who lack adequate health insurance. This is not just a problem for the unemployed. As we can see from the data, the majority of uninsured people are from working families, often in small firms that can't afford to offer comprehensive benefits. The consequences are severe. Uninsured individuals are less likely to get preventative care. They often delay seeking treatment until a condition becomes an emergency, which drives up costs, and they face a much higher risk of medical bankruptcy from unexpected illnesses or injuries. It's a classic example of market failure, where the market is failing to provide a fundamental good to a large segment of the population. The U.S. healthcare system is by far the most expensive in the world, with per capita spending that's significantly higher than other developed nations, yet often with the worst health outcomes. Why? One major reason is the fragmented, multi-payer system. The administrative costs associated with thousands of different insurance plans, each with its own billing and coding requirements, are enormous. The price of drugs and medical services is also much higher than in other countries. The system's focus on acute care rather than preventative and chronic disease management also adds to costs over the long run, as conditions that could be managed easily in their early stages become expensive, life-threatening crises down the road. When we look at health reform debates in the U.S., we see a fundamental philosophical divide. One side, often a more conservative viewpoint, argues that the solution lies in more market competition. They believe that if we empower individuals with tax credits and allow private companies to compete across state lines, the market will naturally drive down costs and improve quality. The other side, often a more liberal viewpoint, contends that the market failures we've discussed are too significant for the private market to correct on its own. They argue that a more regulatory approach, with mandates, subsidies, and government-run programs, is necessary to ensure equitable access and control costs. This is the central tension in all U.S. health policy debates. The Obama proposal, which was signed into law as the Affordable Care Act, ACA, was a massive piece of legislation that represented a blend of market and regulatory approaches. It sought to expand coverage by creating new insurance marketplaces, or exchanges, where individuals and small businesses could shop for plans. Critically, it mandated that insurers could no longer deny coverage based on pre-existing conditions. To make this work, it also included an individual mandate to ensure a healthy risk pool. It also greatly expanded the Medicaid program and focused on paying for quality over quantity in care, with an emphasis on prevention and wellness. It was a complex, and highly controversial, attempt to reform the system. In contrast to the regulatory approach of the ACA, the McCain proposal was a more market-based approach. The central idea was to provide a tax credit directly to individuals to help them buy their own insurance, essentially decoupling insurance from employment. This was intended to make the individual consumer a more powerful force in the market. The proposal also included a plan to allow insurance companies to sell policies across state lines, with the idea that this would increase competition and lower prices. Finally, it proposed making employer-sponsored health benefits taxable, which would remove a major distortion in the market. This approach emphasized individual choice and market competition over government mandates and regulation. Now, let's consider a case scenario. You're advising a nation on its healthcare system. You have two primary models to consider, the US and the Canadian. The US model is a fragmented system where the government is a major player, but the private market, with its thousands of insurers, dominates. It promises choice and innovation but has historically struggled with high costs and unequal access. The Canadian model is a single-payer system where the government finances care for everyone through taxes, but the delivery of care is often still private. It ensures universal access but can face challenges with wait times and a lack of choice in private plans. This scenario forces you to think about the fundamental trade-offs in health policy. In this scenario, we must weigh the different values. The U.S. system, with its emphasis on competition, often prioritizes efficiency and consumer choice. For those with good private insurance, care can be quick and high-tech. However, this comes at the cost of equity, as many people are left without adequate coverage. The Canadian system, with its single-payer model, prioritizes equity and universal access. Everyone is covered, regardless of their income. This, however, can lead to longer wait times for non-emergency procedures and a lack of choice in the types of plans available. This discussion is about how a nation's core values are reflected in its healthcare policy. There is no one right answer, as the optimal solution depends on a country's specific goals and cultural beliefs. For our second scenario, let's focus on the growing epidemic of chronic diseases. With rising rates of obesity and related illnesses, healthcare costs are skyrocketing. This is a perfect example of a market failure. The private market alone cannot solve this because the externalities, the cost to society of unhealthy lifestyles, are not reflected in the price of food or lack of exercise. The person with diabetes will not only face their own medical bills, but their illness also imposes costs on the public system through emergency room visits, lost productivity, and the need for public health services. Therefore, there is a clear economic rationale for government intervention. In this scenario, a government has several tools at its disposal, each with its own pros and cons. They could use an informed approach with public health ads, which is non-intrusive but may not be effective enough. They could regulate by implementing a sugar tax, which internalizes the negative externality of unhealthy food consumption by making it more expensive. Or they could finance by making preventative care widely available and affordable, such as offering free health screenings or subsidizing gym memberships. This scenario highlights the tension between individual responsibility and societal well-being, and the government's role in influencing behavior for a greater public good. While we've discussed the reasons for intervention, we must also acknowledge that governments can fail. A government failure is a situation where government intervention leads to a less efficient or equitable outcome than the market would have produced. This can happen for several reasons. One is political pressure. Sometimes, a politician's desire to get re-elected can outweigh the need for sound economic policy. Another is the theory of local capture, where small, well-organized special interest groups, like a powerful pharmaceutical company, can influence policymakers to create rules that benefit them at the expense of the general public. Finally, government bureaucracies can be slow and inefficient, and without the pressure of competition, they may not innovate or operate as effectively as a private company. These are important concepts to keep in mind when evaluating any government policy. In Canada, the government's role is primarily one of financing. The system is often described as a single-payer model. The federal government sets the rules and provides funding to the provinces, but the provinces themselves are responsible for administering their own healthcare systems. This is why you see some minor differences in care from one province to the next. The core principle, however, is universal access. The Canada Health Act ensures that all citizens have access to medically necessary hospital and physician services without paying out-of-pocket fees. This model is seen as a way to achieve equity and lower administrative costs by eliminating the complexity of a multi-payer system. This brings us to the broader question of the optimal mix of public and private sectors in healthcare. There is no one-size-fits-all solution. A poor country, for example, may not have the tax base to finance a universal public healthcare system, so it may rely more on the private sector. A rich country, on the other hand, can afford to be much more involved. The balance also depends on a country's core beliefs. Some countries, like the US, emphasize individual liberty and market-based solutions, while others, like Canada, place a higher value on social solidarity and equitable access. The ongoing debate between regulation and competition highlights this fundamental difference in approach. To conclude, government intervention in health economics is a complex and often necessary response to market failures. The choice of policy tools and the degree of intervention reflects a nation's values and its economic principles. As we've seen with the Canadian and US examples, there are real-world trade-offs between competing goals like efficiency, equity, and choice. The optimal system for a country is not a simple choice, but one that is constantly being debated and refined. Thank you for your attention.